Good morning, everyone. Welcome this morning. I'm Lisa Tate, Chief Executive with WomenHeart. I see some familiar faces and some not so familiar faces, but I hope that they will be familiar by the time we end this session today. We're so pleased for you all to be with us today as we launch this new initiative for us, our first national educational campaign to specifically address atrial fibrillation and stroke risk in Hispanic women. WomenHeart has been doing a lot of other significant work in the area of heart health and Hispanic women overall, but this is new for us, this specific emphasis on AFib. And we're doing it both because it's National Women's Health Week and National Stroke Awareness Month in terms of launching this initiative today. We're also excited to have the opportunity to be raising the awareness of members of Congress and their staff about this particular issue. It is something that is not even particularly well known or well understood within the medical community and the patient advocacy community, much less in the public policy community. So that's our opportunity today. We also want this to be a really informal session. We have speakers, but we're going to have Q&A, and also I think that this gathering is intimate enough that people can ask questions at any time. You don't have to wait till the end, particularly about the Q&A, etc. We are particularly want to emphasize in terms of policy today the need for research funding on atrial fibrillation and stroke. Why Hispanic women are more susceptible to stroke and specifically debilitating stroke, and why they have worse outcomes than men. Through this initiative, we also seek to educate patients as well as professionals about AFib and stroke. And I think that many of the things that you'll hear today about AFib can be more generalized to women's cardiovascular disease overall, that it's not well understood, there's not enough research, and there are many questions that are still unanswered about why heart disease impacts women differently than men, and in many cases more seriously and unfortunately more fatally. So just a little bit about our organization, for those of you who don't know us. We are the National Coalition for Women with Heart Disease. We're the only patient-centered advocacy organization specifically focused on women and cardiovascular disease, specifically and solely. Our mission is to support women with heart disease and improve their health care and quality of life. We also like to connect them with one another so that they have the support that they need when they have been impacted by heart disease, and to advocate for their benefit. Our message is very simple, and that's that all women deserve to have access to prevention and early detection, accurate diagnosis, and proper treatment. And as we know very well from the work that we do every day as a national organization, the situation has greatly improved in terms of women's cardiovascular health and health care, but there's still a long way to go. We work in several different areas. We work in education, patient support, and advocacy. We educate women on the importance of taking charge of their heart health, and we also train WomenHeart Champions, all heart disease survivors, to carry this message to women and healthcare professionals and the media in local communities. And you're going to be hearing from one of our most stellar WomenHeart Champions earlier today, and we have several others that are our guests in the room with us tonight. You can also contact our Speakers Bureau if you are ever in need of a speaker, because again, we have this national network of trained speakers, and I've mentioned that to a couple of you tonight. So those that represent organizations, we often have our WomenHeart Champs who speak at local events in districts with members of Congress, and as we know, and you'll hear from Mildred, they always do a fabulous job. So please call on us and go to our website for the Speakers Bureau. We are passionate about our mission and our message because heart disease affects so many of our mothers, our aunts, our sisters, our friends. A woman in this country, there is a woman in this country every 90 seconds who suffers a heart attack. And so the commitment that we have today as an organization, as well as the commitment of those of you in this room and those of you that you'll carry this message back to, will actually save lives. We're particularly pleased that we are launching this new Hispanic and Spanish language initiative focused on AFib today. Why this focus? Well, just a couple of more pieces of information around cardiovascular disease and specifically AFib. It's the leading cause of mortality among Hispanic individuals in the United States, and there's a growing population that's at high risk of future cardiovascular disease, morbidity, and mortality as the Hispanic population grows and ages. WomenHeart has invested not just in today's briefing, but in a series of other initiatives, because there have been recent medical studies in the Journal of Women's Health and the Journal of the American Medical Association, just to name two, that show that only 38% of Hispanic American women know that heart disease is the leading cause of death in women, and that 70% of Hispanic American women are living with at least one major risk factor for heart disease, such as high blood pressure or cholesterol. And just to give you a quick comparison, the numbers in terms of awareness of women of heart disease being the #1 killer of women among the Caucasian population, it's like 65%. So it's much higher in the population overall and much lower for Hispanic women. So that is one of the reasons, obviously, that we are focusing our efforts on this both high risk and high need for information group. Data from the Hispanic Community Health Study of Latinos, a specific study, also demonstrates the pervasive burden of CVD risk factors in all Hispanic groups in the United States. Only 15% of Hispanics received medical care for high blood pressure in 2010, compared with 30% of blacks and 20% of whites. Again, high blood pressure, a major risk factor. And among U.S. Hispanic adults of diverse backgrounds, a sizable proportion of men and women had adverse major CVD risk factors. And WomenHeart is determined to make a difference and make a change in these numbers. In addition to this congressional briefing, we're proud to be providing you with some of the Spanish language materials that you see there in what we call our red bag of courage. It's all health education materials that we provide you as a sample, but that are available from our office for you to take to community organizations, other speaking engagements, etc. At the registration desk, you're also receiving a copy of our new magazine, Her Heart Matters in Spanish. That is a 8-page, what we call a magazette, that is specific, again, to AFib and cardiovascular disease. And this is something that will be seen by tens of thousands of women and read by tens of thousands of women because it's distributed through waiting rooms, through physician and other healthcare professional waiting rooms. In addition to the magazine, we've also produced a Spanish language video, which you're going to see, a brochure on AFib, and all of these materials are going to be available through WomenHeart.org, as well as we'll be sharing them with your colleagues, constituents, and families in a variety of ways, and we hope that you will let us know when you have a need for educational materials, again, in Spanish. And finally, this briefing today is being taped and will be posted along with our debut video on WomenHeart TV and on YouTube. We're pleased today to have as our campaign sponsors Boehringer Ingelheim, Bristol Myers Squibb, Pfizer, and Burlington Coat Factory, as well as support from the American College of Cardiology. And we're delighted that our efforts are being supported by long-established, well-recognized advocates for Hispanic health and friends of ours in the health community, the National Alliance for Hispanic Health, the League of United Latin American Citizens, or better known as LULAC, National Council of La Raza, and the National Hispanic Medical Association. So now I have the great honor and privilege and excitement to welcome heart disease survivor and WomenHeart champion Mildred Rodriguez. Mildred is a living example of all that we do at WomenHeart. She's a WomenHeart champion. She runs our first Spanish-speaking support or Spanish language support group in Miami, and has come all that way to share what she knows both personally about cardiovascular disease and also what she hears from these patients that she's supporting on a regular basis in her monthly WomenHeart Support Network meetings. Mildred?
Thank you, Lisa. Good morning. Do you have a nice coffee? That's good, right? Okay. I'm Mildred Rodriguez. I'm a heart disease survivor and a WomenHeart champion from Miami, Florida. Looking back, it is unfortunate to admit that it was simple ignorance to think that heart disease will not happen to me. Although I know my mother suffered and died of heart-related complications, I did not know then that I was heading for the same outcome. I was overweight, smoked, and lived a sedentary lifestyle. feeling fine got me through every doctor's appointment. Then, in 1998, I was told I need an open heart surgery because I suffered a heart attack at my home. I had been better informed. If I had been better informed 15 years ago, maybe I wouldn't have gone through all of that experience. Recovery was very, very scary. The thought of having quadruple bypass surgery was frightening and humbling. After the operation, the doctor told me that my heart was going to be for the rest of my life, so I was very happy. No problem with the heart. Then, 2 or 3 years after the operation, I had a stress test done, and to my surprise, I need to have a stent put in. After this procedure, I realized I had to take better care of myself. At the time of my heart surgery, I do not remember seeing much educational material in the doctor's office, anywhere for that matter, about women with heart disease. Although today we have several sources of information, there still seems to be not enough reaching Hispanic women living in America. One way we could improve this is by educating them early or perhaps during their adolescent years. We could reach them using all possible willing and available sources, which include healthcare providers and the numerous organizations who serve them. We all need continued funding the CDC and the NHLBI for educational campaigns to alert women early on about their possibility risk factors for heart disease. We also need ongoing support to the NIH and the FDA for sex-specific research on drugs and devices to answer questions about the diagnosis and treatment of heart disease in women. With funding for public awareness, education, and research, we can help women take care of their hair health. Sorry, my tongue is twisted. And reduce the numbers of women living with and dying from heart disease. In 2010, I started the first Women Heart Support Network in Spanish for women living with heart disease in Miami. Every day, I feel someone overwhelmed with the power and support and urgency need to bring education for Hispanic women living in America. On behalf of WomenHeart and all women, I urge all of you to please help us to spread these vital heart health messages to women in the Hispanic community. Please help us to save lives. Thank you.
Before I introduce our next speaker, I also want to introduce two other, as I said, WomenHeart champions. Those of you who came in late, Mildred speaks in Miami regularly, both in English and Spanish, to women to educate them, but also our board chair, Carrie Lovelace, who's here in the Washington, D.C. area, and Catherine Brayman back here, who's also very involved in the organization. Did I miss anybody? That's another champion. Great, but thank you all of you for the work that you do every day for the organization and for women. Ooh, I take my notes here. So now it's my pleasure to introduce our next speaker, Dr. Alfred Gomez. Dr. Gomez? Dr. Gomez is coming to us from Miami, Florida also. He is a great friend of our organization, has been involved with WomenHeart on a variety of different initiatives over the last about year and a half. He is Alvaro Gomez of the Baptist Cardiac and Vascular Institute of Miami. He's originally from Panama City, Panama, but he now lives and works in Miami and specializes not just in cardiovascular disease, but specifically in women. And you know what we find in our work around the country, and you know have our great friends here from the American College of Cardiology, is that there are, you know, it's a smaller number of cardiologists that have a specific interest or specialty in women's cardiology. And then when you get into Hispanic cardiologists, again, you know, the number remains small. So we really appreciate Dr. Gomez's both attention to women's issues as well as his involvement in our organization. He has, since 1993, practiced clinical and interventional cardiology at Baptist. He's been a great partner for WomenHeart in our efforts to educate Hispanic women, and he's a fellow of the American College of Cardiology and participates actively in clinical research. So today he's going to specifically focus on AFib, cardiovascular disease overall, and specifically in women and Hispanic women. So thank you, Dr. Gomez.
Thank you, Lisa, and thank you all for coming. As Lisa mentioned and everybody else has mentioned before me, heart disease in women is a monumental health problem that up until recently we have not paid enough attention to. And now patients, physicians, and health organizations in general are finally catching up with the fact that cardiovascular disease is the #1 killer of women by far, double than any other cause of death. So it is very important that we pay attention to all these meetings that we have. And of course, right now is when we're realizing that it's important to get extra funding for research, sex-specific, gender-specific research for women and heart disease. That so far really had been focused on men, which we always felt died of heart disease more commonly. And they still do, but women are catching up pretty fast, particularly in their older age. And the specific topic today is atrial fibrillation. Atrial fibrillation is by far and away the most common irregular heartbeat that there is, and is very common in older women and tends to be more fatal, if you want, in older women. And Hispanic women are a particular risk for this. So we're going to talk about this in a second. I have no disclosures. I have no stock in any of these companies. That's fine. Atrial fibrillation is the most common irregular heartbeat there is, the most common arrhythmia. Up to 2.6 million Americans have it out there. And the hallmark of atrial fibrillation, or AFib, as we're going to call it from now on, is that the heart beats in a very fast, irregular, you can almost say chaotic way. And this is a simple diagram to illustrate this. The heart has its own pacemaker. God was so wise, he gave us a pacemaker that beats regularly at 60 to 80 beats per minute all the time. And it speeds up when we exercise, slows down when we go to sleep. Okay? And here in the middle, we have a bit of a relay station. It acts like a filter, if you want. So normally, each heartbeat gets transmitted one-to-one, and we have a normal heartbeat. It gets transmitted to the rest of the heart. Now, when we have atrial fibrillation, we have multiple pacemakers, if you want. They're firing crazy, each one independent of the other one. So here, it's just a bunch of irregular heartbeats. So this part of the heart here is beating at 300 to 400 beats per minute. Thank God we have this filter in the middle, so we don't beat at 300, 400 beats per minute. So only part of it gets transmitted to the rest of the heart. So the heart beats usually 140 to 160 beats per minute when you have atrial fibrillation, which is untreated. Still very fast, but it's not so fast. But part of the problem is that, yeah, the heart is still going fast, more than normal, but this part, when it's beating 300 to 400 beats per minute, it's like if it wasn't beating. It's just fibrillating. And therefore, the blood can become just stagnant there and can form blood clots. And that is the #1 problem with this arrhythmia. The formation of blood clots in the heart that can lead to strokes. Clots can go to other parts of the body, but they're usually not a major problem when they go elsewhere. But when they travel upstairs to the brain, they can produce a stroke. And it's becoming more and more recognized that atrial fibrillation is one of the main sources of stroke in the United States or in the world in general. And of course, stroke can be related to disability, death. Up to one every other stroke, if you want, particularly in the older population, can be related to atrial fibrillation. And atrial fibrillation can also lead to heart failure. Keep in mind, your heart is beating at 140, 160. It's like you were running all the time, even if you're not doing anything. So the heart can get just tired of that and becomes weaker, and it can produce even heart attacks. And there's a possible link to dementia, with atrial fibrillation because of a chronic low flow state to the brain. Atrial fibrillation can occur just paroxysmal, when it occurs just in bursts. It can be persistent when it occurs up to a week's duration and then it goes back to normal. Or it can be permanent. Patients can be just atrial fibrillation all the time. But each one of these can produce strokes. What puts a woman at risk for stroke? Well, older age. Well, right off the bat, women have the losing end there because more women become older than men. So, after 65, the incidence of atrial fibrillation is higher in women because there's just more women. Okay, family history, obesity is a problem, and that tends to be a problem, I'm afraid, in Hispanic women also. High blood pressure also, and genetically predisposed in certain areas of Latin America. Hispanic women are predisposed to high blood pressure for sure. Other heart problems like valve disease, leaky valves can lead to atrial fibrillation. Thyroid problems, that's very common. That tends to follow a more benign course. You treat the thyroid problem and the arrhythmia goes away. Diabetes, sleep apnea, recognized now as one of the #1 sources for atrial fibrillation. That would be the typical snoring patient, the very overweight, short neck patient that snores really hard that you can tell, this person almost like choking at night when they sleep. Sleep apnea is recognized now as one of the leading causes of atrial fibrillation. In fact, now we do not treat atrial fibrillation aggressively until the patient has had a sleep study and has that sleep apnea treated. It's a fundamental thing that we need to treat before we give any stronger medication for the irregular heartbeat, because otherwise it's going to come back if the sleep apnea is not treated. And of course, heavy alcohol use can definitely lead to atrial fibrillation. Every old cardiology book would have the chapter on holiday heart, the typical person that went to a binge drinking and came back with atrial fibrillation in the ER the morning after. Signs and symptoms. Well, atrial fibrillation, the symptoms can vary tremendously. Some patients don't feel anything, and they show up suddenly because they're out of breath and their heart became weaker after being in atrial fibrillation for who knows how long. And it's very common that we find this problem, we cannot tell when it started. And the patient came in for something else. Sometimes they don't feel anything at all. They just came in for a regular checkup, and they find that the patient's in atrial fibrillation for who knows how long. But there can be other symptoms that could be quite common. You can feel the fast, thready, irregular heartbeat many times. Shortness of breath, if it has produced weakness of the heart already. Dizziness, blood pressure can go lower when you have atrial fibrillation that's going very fast. Chest pain, very commonly, atrial fibrillation triggers a heart attack. Again, is a poor man's stress test, if you want, because the heartbeat is going at 140, 160, or poor women. Fatigue. So 1 in 3 women will not have any symptoms at all. And sadly, the absence of symptoms is more common in women than in men. And therefore, it can go undiagnosed in women for a longer while than in men. So women tend to have a greater risk of atrial fibrillation-related stroke. Okay, the outcomes are worse. Women, the vessels going to the brain tend to be a bit smaller. So it requires just a small little clot to travel upstairs to produce a major stroke. Symptoms can be worse when they occur, okay, in terms of palpitations and all that. But as I mentioned, it's very common for women to not have any symptoms. Control is poorer for atrial fibrillation. Women in general, when it comes to the heart, tend to go to the doctor less often. And they tend to worry about everybody else in the house except themselves. And that is a problem. That is a problem, of course, where women need to be more aware that when they have these signs or symptoms, they need to seek medical attention. And care, up until recently, actually was different. As I mentioned, all these medications we talk about were kind of initially made for men. But now, again, finally, the tide is turning a little bit, and again, the emphasis should be in more research specifically for women in heart disease. So again, early diagnosis is, of course, better outcomes. If you suspect that you have a problem with this in terms of the regular heartbeat, faintly, out of breath, you need to seek medical attention as soon as you can. And of course, if you think you're having anything that sounds like a stroke, you should call an ambulance right away. And many women with this problem can have different opinions or sensations with it. Some of them felt energetic before, and now they don't feel energetic. If you do the right things, and you pay attention to your body. That's a key message. Pay attention to what your body is telling you. You can probably make an earlier diagnosis and reach treatment faster and avoid consequences. So how do we make this diagnosis? Well, key to the diagnosis, of course, is an electrocardiogram, where we're going to see that the heartbeat is irregular, usually very fast, and it's kind of an irregular, chaotic type of rhythm, if you want. The echocardiogram is the ultrasound of the heart. Is an absolute key, essential part of the treatment for atrial fibrillation, because many of the things that we will do or not do will depend on whether the heart is weak or strong, whether the valves of the heart are leaky or not, and gives us really a good overall idea what the prognosis and treatment of this patient should be. So it's fundamental, it's key. Some patients will require the echocardiogram to be done from the inside, like with an endoscope. Now we call that a transesophageal echocardiogram, where we can have a really, really precise picture of what's going on with the valves of the heart. Holter monitor, that's the monitor, is like an EKG you're going to wear for the entire day to really see what the heart rhythm is doing through your normal daily activities, when you sleep, when you go to work. And a chest X-ray, which would be kind of routine. So here the key message with atrial fibrillation is it can lead to strokes. And that is the number one problem with atrial fibrillation, the number one thing we need to avoid. Women with atrial fibrillation have 5 times the likelihood of having a stroke. I mean, 5 times, that's a huge number, than those without atrial fibrillation. 1 of 2 strokes are related to atrial fibrillation in people over 75 years old. And as I mentioned, there are more women over 75 than men. So, of course, this becomes a disease of women in the older age. And you need to find out your personal risk. I mean, not everybody with atrial fibrillation has a very high risk of stroke, and how to prevent a stroke and what to look for. And in terms of finding what the risk is, and this is a question that anybody with atrial fibrillation needs to answer, both as a patient and as a healthcare professional, you need to answer this question. What is the risk of stroke in this particular patient that has atrial fibrillation? And for that, they have devised this scoring system that's called the CHATS-2 score, and it's used now widely throughout the world, I would say, to see what the risk of stroke is. And CHATS, of course, stands for C for congestive heart failure, H for hypertension, A for age over 75, D for diabetes. Each one of these gives you 1 point. And the S is CHATS-2 because a stroke, a previous stroke, or a mini stroke like a transient ischemic attack or a TIA, gives you 2 points right off the bat. So anything over 2, you need to take blood thinners to prevent a stroke. So you can have 2 of these or more, or if you have a stroke right off the bat, you need to take blood thinners. Now, if you think you're having a stroke, you should call an ambulance right away. And what are the typical signs or symptoms of a stroke? Well, numbness or weakness on one side of your body, inability to speak properly, blurry vision, trouble walking, severe headache sometimes. Those are typical signs of somebody having a stroke. And an ambulance should be called immediately, because now, just like we have heart attack teams, hospitals have stroke teams. So if anybody has a suspicion of a stroke, it needs to be taken by ambulance right away to a hospital. They do all the testing, and they'll be assessed immediately. And if they confirm you're having a stroke, then you'll get the same clot busters we used to give for heart attacks before. And because many of these strokes are produced by blood clots, they actually produce tremendous results. and the stroke is basically aborted right there, and patients recover much, much better. So again, the critical importance of calling an ambulance when you think you're having a stroke. And then, of course, these patients will be worked up to see if there's a cardiac reason for the stroke, mostly if the patient has atrial fibrillation. Okay. So how is this treated? Well, there's two goals with the initial treatment for atrial fibrillation. First is to keep the heart rate slower, because it tends to go very fast. Ideally, to revert the rhythm back to normal, if that could be possible. And to give medications to prevent a stroke. Again, as I said, that is the most important thing, is to prevent a stroke. And to manage atrial fibrillation really requires a team approach. It's not just the doctor giving some pills. No, it needs the medications. They can be procedures. But the patient also needs to adopt a heart-healthy lifestyle, of course. All these things are related to risk factors that are controlled by lifestyle modification in terms of, we'll talk about those later. And you need to partner with your healthcare team, not only the doctor, the nurses that take care of you also, nutritionists if that's available. All those things are important. And avoid triggers for atrial fibrillation. We can talk about that in a second. Medications, crucial, of course, for the management of atrial fibrillation. We can have medications to just slow down the heart rate, and that would be we call just rate control. We can give medications to try to convert the rhythm back to normal. Usually we don't do that right away. We like to kind of, things to settle first. And the medications to really revert the rhythm back to normal tend to be a bit more toxic, if you want. They can have many more side effects. So the initial attempt is just to control the rate, so the rate doesn't go too fast. And we're going to give medications to avoid blood clot formation in the heart. In that area of the heart that we mentioned is not moving very well. And that would be what we call an anticoagulant, or people would call it blood thinners. They prevent the formation of blood clots, and that's exactly what we want. The one that's been used for decades, many years, is called warfarin or Coumadin. So that's a commercial brand name that it used to have. Coumadin has been used for years and years and years. It is true that patients sometimes complain that it's a right poison. That's exactly what it was. But we found this extra utility for it. It thins the blood very well. The only problem is, it's very effective, and it's been the mainstay of treatment for a long time. But it needs to be monitored very closely, because the levels can vary with many things. Diet, different foods can change the levels. Different medications can vary the levels. So it needs to be monitored very, very closely. And it's important to keep the patient right exactly where they need to be, because the blood is not thin enough, it's not preventing strokes. If it's too thin, patients can bleed. So it's very important to monitor this all the time. Now, there are newer medications which are really a great thing. Patients love them. The newer anticoagulants that have similar positive results with Coumadin in terms of preventing a stroke, but we don't need to monitor them at all, basically. You just give them medication like taking an aspirin, where you don't need to monitor anything. You just take it every day, and you're done. So they have really kind of changed the way we manage these patients. Patients absolutely love them. But the decision on which one is correct one for you needs to be done with your cardiologist. Not everybody can take the newer ones. But the decision, again, it has to be a long discussion with your cardiologist to see which one is the right one for you. Cardioversion. This is a way we can slap the heart, if you want, back to normal. And this is what you're all used to seeing in programs like ER, the shock, the electric shock. And this is, of course, done under very controlled environment. The patient's under anesthesia, so they don't feel anything at all. And we give them an electric shock, and the vast majority of the time it works. And the heart is slapped back to normal, if you want. And the heart it continues back to normal unless there's something other trigger. For instance, we would not do this if the patient has not been worked up and treated for sleep apnea, we mentioned before already. Because otherwise you end up cardioverting that patient every month. It's going to come back no matter what. So you need to treat all the other potential triggers before you go for this. Ablation is another modality that's been used more and more, where you basically insert a wire, a very specialized wire, from the groin to the heart. They can detect where the fibrillation comes. And with the same wire, they will give you a little shock of basically the same microwave oven energy that you have. Radio frequency ablation is called. So they burn that small area of the heart that's producing the stroke, the fibrillation, and the arrhythmia is eliminated. So it's a fantastic system to treat this problem. And then surgical maze. This is now kind of been relegated to patients that actually are undergoing open heart surgery for other reasons. And they happen to be in atrial fibrillation, where the surgeon would basically create like a labyrinth, if you want, in that area of the heart that had all the irregular heartbeats here. And basically they redirect the electrical impulse in a way that now it becomes more organized and the fibrillation goes away. Okay? It used to be a treatment before ablation. We would send patients specifically just for this when the arrhythmia was very difficult to control. Nowadays, with ablation, it's being used less and less as a primary option. It's being used mostly if you are going to open heart surgery for something else, then you can have a maze procedure right there. Then we had to avoid triggers: caffeine, alcohol, very, very heavy, super heavy exercise, extreme stress, and as we mentioned, sleep apnea is very important. Heart-healthy lifestyle, crucial. Just exercise, eat right, follow listen to your body and see what's telling you. Limit your alcohol and caffeine. A small amount of alcohol is actually healthy. Too much is a problem. Don't smoke, of course. That goes without saying. Partner with your healthcare team. Communicate, be in contact with them. Doctor, healthcare professionals, like working with your doctor, nutritionist, very important. This one we're going to go. So, how to stay in tune. See what can trigger an episode. Some patients can tell, if I do this, this happens, well, avoid it. Know your risk of stroke, crucial. Healthy lifestyle, crucial. Pay attention to how you feel. Listen to your body, listen to your heart. Risk factors, modify them. Blood pressure, smoking, obesity, sleep apnea, we mentioned that. Medications, of course, take them out the way you're supposed to. Pace yourself, and support systems. It's been talked about here before. Crucial in terms of coping with your disease and knowing what to do with it. Important questions. How can I decrease my risk? What type of AFib do I have? What do I need to do to prevent this? And what medications and what point do we need to consider an ablation or cardioversion, the shock? What kind of exercise can I do? And I think that concludes my presentation. Again, this is a tremendous healthcare problem that we need to address. And as I mentioned, Hispanic women tend to be at particularly high risk for this. There are a lot of older Hispanic women. Old age is a risk factor. Again, obesity, common in Hispanic women. High blood pressure, very common. A main source of atrial fibrillation is high blood pressure. And we need to start really dedicating more funding to specific research in women with heart disease. So thank you once again, and I think next is going to be the video presentation. Or next speaker, sorry. Okay.
Thank you, Dr. Gomez. And I think that presentation makes very clear why it is so important that we're focusing on this issue today. I also, though I do know quite a bit about AFib, I've learned a whole lot that I didn't know today specifically and have some specific questions. But I'd now like to introduce Marcella Gaitan of the National Alliance for Hispanic Health here in Washington. The Alliance is the nation's foremost source of information and trusted advocate for health of Hispanics in the United States. We have worked for years, or I've worked for years, both at WomenHeart and other organizations with the Alliance. Marcella is Senior Director for External Relations there. She leads multiple health outreach initiatives. She's, as Alliance's Senior Policy Advisor, Marcella takes the lead on national health and human services policy and guides efforts to create leadership networks to improve the health and well-being of Hispanic communities. So we welcome Marcella and look forward to your comments. Thank you.
Good morning. Thank you for being here, and thank you for the invitation to having us here to give our perspective for women, the atrial fibrillation and stroke risk among Hispanic women. Okay, just a quick overview of the Alliance. We're a nonprofit organization. We're based here in Washington, D.C. We work with a network of community-based organizations around the country. We're a public health organization, so we focus on health promotion, health education programs. And our mission is to improve the health and well-being of Hispanics and work with others to improve health for all. We are the largest and oldest Hispanic network of experts in Hispanic health. We are believing community-based solutions. That's the core of our program, our programs, and do not accept money from alcohol and tobacco companies. And we work with a network of agencies, as I mentioned before, that provide services to over 15 million Hispanic persons around the country. Now, in terms of the AFib in Hispanic women and the risk for stroke, there are a couple of things that I would like to emphasize, even though Dr. Gomez and Mildred already mentioned, but it's kind of reiterate the message in terms of what we need to do to prevent this. Now, if we look at this table here, in terms of not having enough, one of the key things in this issue is we don't have enough data for Hispanic women especially. And if you look at this, not until let's see, 87, like NIH publishes policy in NIH guides to grants and contracts that urges, okay, urges only, inclusion of women, and later on they revise it for minorities. Now, so not until 95, we have that all the NIH grants and contracts had to include women and minorities. So it's not too far away. I mean, not too long ago that we actually started to look for data in terms of inclusion of women. And also in terms of Hispanics, we cannot forget that you know, there are different groups of Hispanics. We cannot just lump them all in the same group and say they're all the same. No, because we have different subgroups. People from Mexico, people from Colombia, from the different countries. We all have different, overall, you know, we speak the same language, yes, but you know, our cultural issues tend to change, believe it or not, even between countries next to, like, let's say I'm originally from Colombia, and I have colleagues from Venezuela, and you compare some of the cultural issues among the two countries, they are very different sometimes. So, and we also have to think about our ancestors, our genetics, our environmental exposures too, to think about the issues that affect the health. So, in terms of challenges for Hispanic women that they face for the prevention of strokes and the treatment and I guess, more of the education about AFib and prevention of a stroke. We look at the challenges that had to do financial, cultural, language barriers directly impact the rates of this heart disease morbidity and mortality. We look at the disparities, and this is actually reported from the HARQ, the Minority Disparities Report actually, that in quality of care, Hispanics still receive worse care than non-Hispanic whites for over 39% of the measures. And in access to care, we also see that Hispanics has worse access to care than non-Hispanic whites for 63% of measures. So we have at this, consistently, every year the report is showing that in different areas of care, Hispanics still lag behind in compared to other racial and ethnic groups. So that definitely will affect the way, especially women, will look for care. And we're looking at some of the ways that we could actually help women for the prevention of AFib and actually prevention of a stroke mostly. We look at, for example, maybe possibility of create an educational campaign that actually addresses detection of irregular heart rhythms that they can help with the early diagnosis of AFib and especially the prevention of a stroke. Like Dr. Gomez mentioned, Hispanic women tend to put their family first. So, you know, the kids are first, the husbands, the partners are first, and then they go after that. So, like he was saying, many women tend to ignore the signs because maybe you have a little heartbeat, oh, that's, you know, tachycardia, oh, that's fine, I'm maybe a little too stressed. You know, maybe the kids are making a little too stressed. So they tend to put that aside. So that's one thing that we need to emphasize among women, that we need to pay more attention to our health. And then that way we can actually take better care of our families. Again, to help them to identify and address the risk factors associated with heart disease. Because still, that's an area where women still tend to be not very knowledgeable in terms of knowing the risk factors. Yes, we hear about, you know, we need to have a better nutrition, but they don't know, for example, about many women do not know about high blood pressure, cholesterol. And then that's from the numbers that we get from the CDC or from the American College of cardiology or even from the American Heart Association, a lot of, in the Hispanic population, a higher number of people do not know they have high blood pressure. So and it's like we were talking with Mildred, the silent killer. They have no symptoms, so they don't know they have a high blood pressure. So that's one area that we also need to emphasize, learning about the risks. And then successful prevention depends on a supportive and accessible healthcare system to facilitate early diagnosis and proper treatment. That's also key. Now, in terms of more in the area of policy and the challenges that we have right now, we're looking into the area of affordable source of care. And again, this is another area that is important to take into account. Among Hispanics in general, majority of them do not have a regular source of care. And that goes as a result of the fact that many do not have health insurance. You know, a lot of them are working uninsured because a lot of the work they perform, they do not provide health care, health insurance, I mean. And in this case, if we want to work in terms of detection management or AFib in the prevention of a stroke, you know, the regular source of care is key in this area. And then another area that we would like to emphasize is the area of strengthening community-based organizations to connect Hispanic women to culturally proficient, linguistically appropriate AFib outreach and education programs, focus on prevention, early detection, and management. That's an area that sometimes we tend to forget. And we think, oh, no, it's going to cost a lot of money. We need to find bilingual providers. A lot of them are already in the community. We need to access, we need to support these agencies. And some of the agencies that we actually work with at the community level, they do great work. They're already in the neighborhood. They are trusted by the community. They have the language factor that is not a barrier for the people that go to care. They have the cultural knowledge. So that's a resource that sometimes goes not kind of ignored in many areas. And if we want to look for prevention campaigns, we want to look for education campaigns, these are the agencies that they can actually help a lot in this area. And then I would like to mention about this. I'm sure most of you know about the National Heart, Lung, and Blood Institute is conducting a study. It's already probably 3 or 4 years now in the way, and is looking the first epidemiological study of Hispanics in the United States. And we're very optimistic that the results from the study will probably provide us show a light of what's going on with the Hispanics in the United States. And the good thing about this study is that they're looking at the different Hispanic subgroups. It's doing it in 4 different cities: Chicago, Illinois, Bronx, New York, Miami, Florida, and San Diego, California. So they're looking at South American, Central American, Mexican, and Puerto Rican communities, and they're looking at identify the prevalence and risk factors for disease, disorders, and conditions. So we're hoping in the next couple of years or so, I think we're hoping some of the first results will be coming out in the next year or so, and maybe we can have some idea of what are the protective factors for the Hispanic community, and what actually we can take from here to help women in the prevention of AFib and stroke. And I just want to mention a couple of resources that we have at the Alliance. We have helpline, the Su Familia helpline, where women around the country can call with their, and it's a toll-free number. They can call, and we provide information on different areas of healthcare. We can also be, depending on the zip code, we can refer them to the closest health provider. We have a database where we can tell the women, or we can tell the consumer where they can go to receive health care. And we also have the Buena Salud Club, and we also have our social media network. Thank you very much.
Marcella, thank you. Please have a seat there. We now have time for some questions. I have a question right off the bat for Dr. Gomez while you all are thinking of your question. But you mentioned that women are less likely, less likely to have symptoms that are visible than men, or that exist in men. And I was wondering is there any research or why that is?
No, there's no.
That's always the answer.
Exactly, that's a simple answer. It's kind of 2 extremes, if you want. It's a large percentage of women do not have symptoms, but then when they do, they tend to be more dramatic, if you want, in terms of feeling the regular heartbeat, feeling the faintness, the shortness of breath. But it's very common for women to not have any symptoms. Or if they do, and actually when you go back and you really kind of dig in the history, they probably have had symptoms for a long time, But like it's been mentioned before, they just did not pay attention to them. Okay. And they felt that taking care of the rest of the family was more important than going to see the doctor. So there's no research exactly why that happens. I'm not sure we could find an answer specifically, but it is a known fact. There are gender differences in terms of the symptomatology, not only for atrial fibrillation, but for many other diseases, for sure.
Well, another reason that we need more research specifically on women. Other questions?
So this is for any of the panelists. In terms of reaching the Hispanic women, is social media effective at all? Are Hispanic women on social media, is the internet a good way to reach them, or are there other means that are more effective?
I can say that based on our experience with the social media that we've been implementing in the past, I guess, year or so, we know that women are looking at social media. They're looking at Facebook, they're looking, they do texting. In fact, some of the campaigns that we have carried out with other programs have included texting campaigns, and we know they're successful. Also, in terms of like Facebook also, and we notice some of the comments that we get in our Facebook page from women also, it's an effective way to reach to women. But we also, another area that we do is that when we provide, and maybe it's something to keep in mind, when we provide information at the community level, when we provide publications, we do them bilingual. Because we know in the family, you have the grandmother to the kid that's going to school. So those kids are bilingual, and sometimes actually I have to say they probably speak mainly English. They might understand Spanish, the grandmother might talk to them in Spanish, and they'll probably reply to her in English. So we tend to do our publications bilingual. That way we know we can reach everyone in the family. And also community agencies. We know they are definitely the areas where a lot of the women go for care. And in general, especially if they're uninsured, they're in the neighborhood, we know they tend to go to these community clinics, but because they know the people there, many times even working with promotoras, with lay workers in the community is also quite effective, and especially if you want to do an outreach campaign to educate women. A lot of these agencies also have programs where they do nutrition sessions, they can do maybe exercise sessions. So in a lot of the community participate in those. We have our annual event that is called Get Up, Get Moving. We're trying to get the message out there to improve improve the lifestyle, to make it more healthier. And then some of the areas that we emphasize there are physical activity. So we have an event, and we partner with these community-based agencies in different cities. And we have a day event that is for the family. And for example, we do activities for the kids. We partner with the U.S. Tennis Association. We partner with the U.S. Soccer Foundation. With local agencies that do activities for kids. But we also do screenings. We do cholesterol, we do high blood pressure, we do diabetes. And we work with other organizations like advocacy organizations to provide the messages for the communities. So when the whole family comes, because we see, I've been to the events and I see the grandmother with the daughter, with the baby, everybody come to our table and they get the information from us. And that's how we know that all of them are doing texting. Probably not much as we would say the grandmothers, but I know the younger generations definitely are into social media and internet. So.
Yeah, just to expand on what Marcella is saying, which is all those are great pieces of information. The Hispanic families tend to be a bit more old-fashioned nuclear families where everybody kind of lives in the same house, 3 generations, etc. And even though the older lady will probably not read Facebook, the younger ones will. And it's very common that the older members of the family are dragged into the doctor's office by the younger ones. So if you want things to happen, you target the younger guy in the house, and they'll make things happen in that house. And so therefore, yes, the answer is no. Abuela, or grandma, may not read Facebook, but the guy is going to take her to the doctor's office or the hospital does. So yes, it is definitely an effective way of sending the message out for sure.
But I think that it's not just for the grandmas or the young ones, because sometimes in the houses, the young ones, they don't want to take the time to explain to the grandma what is happening or what can happen to them. So I think that we have to reach all ages and everybody.
Okay. Other questions? Nicole?
For Dr. Gomez,
Yes.
you mentioned that 15% of the patients in the Hispanic population are only 15% are being treated for hypertension, which means that we've got like over 85% not being treated. Is the problem that they're not going to the doctor because there's not time, or they're going to the doctor and they're afraid to speak up? And if it's a problem speaking up, what can we do? I work for American College of Cardiology. What can medical associations like us do to change the conversation?
Yeah, well, high blood pressure, thank God, it's one of those things that you don't need to talk too much about it. It's there. When you check it out, it's just there. So it's really, the most important thing is to take that first step of actually going to see the doctor or a healthcare professional in general. And that is the missing step. You know, that, again, women tend to not pay attention to that particular thing, or they pay attention to other things except cardiovascular health. And again, the crucial part is to go and be checked out. You know, and once they do that, you know, all the things come up. And again, high blood pressure is one of those things. So it's just detected, you know, in the normal routine physical exam. It's important to raise awareness of doing that, because, you know, untreated high blood pressure can trigger so many other things. You know, fibrillation, one of those. It can lead to, you know, it's the #1 cause of congestive heart failure in the world. Maybe not so much in the U.S., but in the world it is. So it's still the silent killer that we need to address.
But I think that we have to educate the Hispanic women, because we don't know what to ask, how to ask, or when to go to the doctor. So I think that we have to educate that first, and not to be afraid to ask to the doctor. And don't think that, sorry, doctor, that you have the last word. Because sometimes we have something
It's the
else.
truth. It is the truth, yeah.
Other questions? Oh, yeah?
Yeah, Ms. Gaitan,
Yeah, it's actually.
pointed out that there are big disparities in access to care for Hispanic women, some of which the financial barriers should be addressed by the Affordable Care Act. So I'm wondering if you can elaborate a little bit on some of the other barriers to access that confront Hispanic women and that won't be addressed by the Affordable Care Act.
Okay. One of the other areas is the cultural issues. I'm talking about, for example, like Dr. Gomez was mentioning, in our community, like Mildred would say, you know, we still see the doctor as kind of the person, whatever the doctor says, we could do it. And that's kind of in general for the Hispanics community. But then the communication issue is a big barrier, because many times when the patients go to the doctor doesn't know much about the culture, doesn't know much about the language. Is the women or the patient in general will have a hard time asking questions. Sometimes you have the help of a translator, interpreter, for example. And that helps, that definitely helps and improves the communication. But when it's not like, when it's one-to-one and it's a communication barrier, that will kind of deter, I will say, the patient to go back to the doctor unless the person speaks the language. And you can see that, and that's what I was talking about, community-based organizations, community clinics. Many times they have the provider that is bilingual. So that helps a lot. That improves in the area of communication and in the area of access to care. And that, you know, that goes with the language barriers and the cultural issues in terms of looking at what would be the ways to improve the care for Hispanics in general. And again, I think with the Affordable Care Act, one of the areas that they would like to, or that is part of it for improvement, is the inclusion of increasing the number of providers from different racial and ethnic backgrounds, which I think it will improve overall in the general care of the population, especially we're looking at the increasing numbers of minorities in this country.
Great. Any last questions? Michelle?
Dr. Gomez, I'd like to ask you, do you think there would be value in screening the general public for AFib? There's a number that we hear, and I can't validate it by naming the source, but we hear there may be as many as 5 million Americans that are undiagnosed that have AFib. And do you think there's value in trying to screen the general public and connect them now that the ACA's movement is here? And I know we're going to have some trouble with that, but we're going to pass those bumps. Do you think there's value in that?
Well, the thing is that to screen for atrial fibrillation is just as simple as the regular physical exam. Now, it doesn't require, I mean, once you diagnose it, of course, it requires extra testing. But to make the diagnosis of atrial fibrillation is not like screening for cancer, for instance, where you actually need a specific test or a specific procedure. For atrial fibrillation, all you need is that initial physical exam, and any healthcare professional that takes your pulse can check, oh, this patient has atrial fibrillation. Okay, so that's really all we need, is to get the public to go ahead and get checked out. And if you feel anything irregular like that, just, so the diagnosis is so simple, it doesn't require any major screening, just to see a healthcare professional. And that's about that. Now, once that happens, then of course, there will be other tests that will be required. And a crucial area of interest is going to be the older patients with stroke, where there's many that advocate, because many times they come in with a stroke, you don't see the fibrillation, but then when you see them in the office, they had some fibrillation every now and then. So many doctors advocate that we should treat the older patient with a stroke like all of them, like they had atrial fibrillation, at least initially, until we really sort it out. But in terms of screening, initial screening, again, all it takes is just a plain physical exam and an EKG that any office will have, any medical office, anything that has related with health will have an EKG machine nowadays. So.
Great. I think
But
we'll,
go ahead. I think that what you said is true, that sometimes we don't know that we have atrial fibrillation, because sometimes we say, my heart is beating so fast, or I have tachycardia. I don't know how you say it.
Yeah, you have tachycardia. Yeah,
So, and then we have atrial fibrillation, but we don't know that is that. So, as the doctor said, we have to go there.
Yeah, and again, raise awareness. All these campaigns are so important, for women to know what to look for. Okay, I'm feeling this. Let me have this checked out. The dinner for the rest of the family tonight can wait. They can eat whatever else, but I need to have this checked out.
I think we'll close on that important note, which is dinner for the rest of the family can wait tonight. And I'll take that home to my family. But I do want to thank everyone here for attending today. I mean, I've learned a lot. I hope you all have learned a lot. I hope you have taken information that you can take back to others in your organization and staffers here on the Hill. I want to particularly thank our speakers, Mildred Rodriguez, Dr. Gomez, Marcella Gaitan, I do know your name, and really appreciate everything that you have to say. Also, our sponsors, Boehringer Ingelheim, Bristol Myers Squibb, Pfizer, Burlington Coat Factory, and the American College of Cardiology. Thank you all very much. Susan Campbell, I want to introduce her, our Director of Policy at WomenHeart. Many of you know her, but she's always available for follow-up, as are any of the staff here at WomenHeart. I want to thank the staff that put this together at WomenHeart, which includes Lisa Clow and many others here in the room, but thank you all very much for that. And we're going to close here with the video. If you have time to stay, it's what, 7 minutes? 5 minutes, 5 minutes. Oh, okay, there you go. Well, but we'll go ahead and close here. Absolutely. Thank you all very, very much. And we're here available for questions as we leave.
Mi nombre es Consuelo Córdoba, nacida en Cuba, pero vivo en los Estados Unidos hace 53 años. Cuando fui diagnosticada con Atrial Fibrillation, fue una sorpresa muy grande para mí. Yo no tenía síntomas ninguna de esa enfermedad, simplemente había veces que me sentía cansada, otras veces me sentía falta de aire, pero como yo soy asmática, siempre asumía que era por el asma. Fui a hacerme un chequeo general con mi médico y el doctor me hizo un electrocardiograma, el cual dio irregular. Me dijo que yo tenía mucha irregularidad en ese electro y que tenía que ir a ver a un cardiólogo. Cuando fui al cardiólogo, me dijo que lo que yo tenía era AFib.
La fibrilación auricular es un trastorno del ritmo al corazón, es la arritmia cardíaca más común que hay y está identificada por un pulso irregular y bastante rápido. La fibrilación auricular puede tener varios síntomas, principalmente palpitaciones debido a que el pulso puede ir bastante rápido. También puede haber falta de aire, dolores en el pecho cuando hay enfermedad coronaria también. Y si el pulso va muy rápido, también puede haber mareos o sensación de desmayo. La fibrilación auricular se diagnostica principalmente con un electrocardiograma. En el electrocardiograma se puede ver que el ritmo es irregular y es rápido. Y hay ciertas características en el electro que nos permiten decir que el paciente tiene fibrilación auricular. Ahora, una parte importantísima en el diagnóstico de la fibrilación auricular también es un ecocardiograma, un ultrasonido del corazón. Porque es importantísimo saber que el corazón sea de tamaño normal, que no esté grande, que el corazón esté fuerte, que esté bombeando a su capacidad completa y que las válvulas del corazón estén funcionando normalmente.
Mi familia estuvo bastante sorprendida. Yo tuve la suerte de cuando fui al médico, fui con mi esposo. Él estaba allí cuando me lo dijeron. Tanto para él como para mí fue un momento tenso, porque yo no pensé realmente que yo tuviera eso. Yo pensé que era simplemente que tenía una taquicardia y ya. Para mis hijos también fue un momento de tensión, porque los hijos siempre creen que mami nunca se puede enfermar.
La complicación más temida de la fibrilación auricular es una embolia cerebral. Cuando el corazón está en fibrilación auricular, hay diferentes partes del corazón que están latiendo a 400 latidos por minuto. O sea que desde el punto de vista práctico efectivo es como si no estuvieran latiendo. Y de esa forma se forman coágulos de sangre dentro del corazón que bien pueden desprenderse del corazón y ir a la parte superior, para el cerebro, y provocar una embolia cerebral con todos los efectos nefastos de una embolia cerebral.
Me dio mucho miedo porque yo creo que lo más importante en una persona es el corazón. Cuando uno tiene algún problema con el corazón, es más difícil de poder lidiar que con otra enfermedad. Yo creí mucho en el médico mío, en el cardiólogo mío. Él se sentó, habló muy bien conmigo, me explicó todo lo bueno y lo malo de la enfermedad que yo tenía. Él me dijo que las personas del AFib tienen un riesgo muy grande a producir coágulos, cuyos coágulos producen el stroke, que es la embolia. Si una persona se controla y sabe lo que tiene que hacer, sobre todo con los síntomas que uno pueda tener, es menos riesgoso a que te dé una embolia.
Bueno, cuando una mujer piensa que puede tener fibrilación auricular en cuanto a los síntomas de palpitaciones, dolor en el pecho, falta de aire y o mareos. Entonces, ¿qué hacer con los síntomas y dónde ir a tratarse? Depende de la intensidad de los síntomas. Pero es importante tratarse en un futuro próximo, que lo vea un médico lo antes posible. Si los síntomas no son muy severos, podría esperar a ir a la oficina médica de su médico de cabecera o su cardiólogo para verse si es posible ese mismo día o al día siguiente a más tardar. Por otro lado, si los síntomas son muy intensos en cuanto principalmente dolor en el pecho y falta de aire, que la paciente se siente que no está estable y que no puede esperar realmente la cita médica el mismo día o al día siguiente a más tardar, entonces es importantísimo que vaya al cuarto de urgencia más cercano para ser tratada entonces con las medicinas que sean necesarias para controlar el pulso y para anticoagular a la paciente. El tratamiento de la fibrilación auricular tiene dos etapas. La parte inicial del tratamiento, principalmente tenemos que controlar el pulso porque es una arritmia que tiende a ir bastante rápido, y también tenemos que anticoagular al paciente, darle medicinas para poner la sangre fina y evitar la formación de coágulos de sangre que provoquen una embolia cerebral. El tratamiento avanzado de la fibrilación auricular, principalmente la meta es quitar la arritmia. Y para hacer eso hay varios métodos, ¿no? Hay, primero que todo, antiarrítmicos bastante fuertes. Hoy en día hay medicinas bastante efectivas, bastante fuertes para evitar que la arritmia regrese, ¿no? o para eliminar la arritmia completamente. También hay lo que llamamos una cardioversión, donde se puede dar al corazón un shock eléctrico, como ven ustedes a veces en las películas o en la televisión, bajo sedación, por supuesto, con anestesia. Se da un shock eléctrico al corazón y con ese shock eléctrico el ritmo del corazón puede regresar a la normalidad. Una parte del tratamiento que es importantísima también, uno de los factores de riesgo número 1 es lo que llamamos la apnea del sueño. Aquellos pacientes que roncan mucho, sobre todo los pacientes con cierto sobrepeso y que roncan bastante, es un factor de riesgo importantísimo, muy reconocido hoy en día para la fibrilación auricular. Y parte del tratamiento de la fibrilación auricular es el tratamiento de la apnea del sueño.
Teniendo AFib, Atrial Fibrillation, no me ha afectado tanto mi rutina diaria. He aprendido a lidiar con eso y hago mi vida normal. Me levanto igual que todo el mundo, voy a trabajar, preparo la comida, salgo a pasear, voy a donde quiera, no pensando que yo tengo una enfermedad. Para mí es muy importante que todas las mujeres entiendan que nosotros no somos de hierro, somos de carne y hueso, que todas las mujeres tienen derecho a enfermarse y derecho a tener un problema. Hay muchas mujeres que no tienen tiempo a decir, oh, me duele el pecho y eso no es nada, es un gas que tengo. Oh, me falta el aire, eso es un catarro que voy a coger. No, siempre tienen que estar alerta porque un dolor de pecho, una irregularidad en el corazón, o sea, una taquicardia, una falta de aire, es un síntoma muy importante para la salud. Y la mujer no debe de tener miedo ni debe de sentirse que no es lo que debe de ser en su casa porque tenga que ir a un médico. Siempre que se sienta mal, vaya, que hablando con un médico, entendiéndose con su cardiólogo, va a vivir mucho mejor que omitiendo ese momento en su vida.
Oh, fantastic. Thank you very much for doing this. Good, good. Don't go too far because I want to talk to you too. We do a series, I work for Cardiosmart. Yeah. You work for Cardiosmart. So we do a series of lunch and learn community events called Living with AFib. Yes. So I wanted to know if you were, oh sure, yeah, I can come on.
That'd be great. Yeah, that's fine. That's fine. That's just kind of background to helpful to us launching into this space. Yeah. So we're going to be following up with you on a little bit to collaborate a little bit more. No, equally. Yeah, no, it's definitely a need and game. I always emphasize skills. It's one thing that yes, that would be great, and I'll get you mine as well.